Thank you for joining us. Welcome to the session for the day. If you're with us live, we hope to have you back tomorrow. This Tuesday closing session will be with Layla Andoni, a genetic counselor with Intermountain Health in Salt Lake, Utah. Layla will be showing us how to deliver a difficult diagnosis with hope. I'm Cody. I'll be your moderator for the session, and then Christy will share a little about MSRGN after our Q&A. And with that, I'll hand it off to Layla to close us out.
I have my slides up here. So hello, my name is Layla Andoni. Thank you for that introduction. I'm a genetic counselor, as they said, at Intermountain Healthcare in Salt Lake City, Utah. And I've been a genetic counselor for just over 6 years and have worked with patients and families in a variety of clinical settings. And that includes prenatal, pediatric cardiology, adult neurology, as well as having some laboratory experience. I will be talking about delivering difficult news with hope, and I have the tough job of following all the other amazing speakers today and closing out today's sessions. So I hope you all have been enjoying this conference as much as I have. So I have no conflicts of interest to disclose. When the Mountain States Regional Genetics Network approached me about this talk, I was excited to be able to share information on a topic that I'm passionate about. Specifically, my understanding is that families were interested in this talk because of their personal experiences and to educate healthcare providers. It also sounds like the healthcare providers that are part of the group want to know more about how to improve on this skill and how to train others. So today I'll be reviewing effective models for delivering difficult news and training methods, along with sharing some resources and a family story. So to get us all on the same page, why don't we start with some background? And I think importantly, let's start with the definition of difficult news. The definition of difficult news that I use is from a paper by Dr. John Carey and Karen Dent, which defines it as new, unexpected, life-changing, or unwelcome information. Difficult news is unique to each person. Its magnitude is determined by the person's life experiences, familial and social connections, medical history, emotional hardiness, spiritual beliefs, and the surrounding cultural and environmental context in which the difficult news is received. I will say we're talking today about diagnoses, but it isn't always a test result or diagnosis. Sometimes difficult news can be the lack of a diagnosis, so people still going through that diagnostic odyssey and looking for answers and feeling disappointed there, or other types of health information. And I think that's important to realize as well. So recommendations on how to best deliver difficult news have come out of the research on both healthcare providers and patient experiences. I think it's really important because we know that the way news is delivered, it does make a difference. A poor job of delivering difficult news can leave a patient confused and distressed. We want our patients to feel heard and supported. We know that patients prefer good communication, expression of feelings, adequate time, and confidence. But both anecdotally and in the literature, there are stories of people dissatisfied by the way difficult news is delivered. I know some people's first question might be, well, will anyone ever be happy with difficult news? Are we just shooting the messenger? But I hope to convince you that there really is a better or preferable way, and you can leave people feeling more empowered and supported. And as the title of this talk says, hopeful. That being said, delivering difficult news, well, it's difficult itself. Researchers have noticed something called the mum effect, and that's when the stress of delivering difficult news, it creates a reluctance to deliver the news in the first place. And maybe all of us in the audience could relate to this. Maybe you've had a test result on your desk that you're anxious about calling out, or in everyday life, something that you're procrastinating on, and that's the mum effect. But training does help, and we'll dig into that more later. First, let's look at some of the models for delivering difficult news. I'll briefly go over 3 from the literature, although there are many more that exist if you go look. So you can pick the acronym that you relate to most or that works best for you. I'm going to spend the most time on the SPIKES acronym. This protocol, it was initially designed for oncology care, but I see it referenced a lot in the genetics literature. So with this, S, setting up the interview, is where we start. And things that are important here are maintaining privacy, involving significant others, sitting down and connecting with a family, and making sure there's no interruptions and that you have adequate time for the encounter. Assess the patient perception, and this can involve asking questions, and these questions might depend on whether you have rapport, you've established a relationship with the family before, or if you look in the literature, for some healthcare providers, delivering difficult news can simultaneously be their first encounter with the patient, which is tough. But asking questions helps. What have you been told about why you are here? Or if you do know the family, check in about what they've been thinking since you last talked. You know, sometimes in these situations, families have a lot going on. Sometimes people need a refresher on who I am, what results I'm even disclosing. Other times, families have been eagerly at the edge of their seat waiting for news. So, depending on that scenario, you might have to provide different amounts of background or context and have a different conversation. So, then obtain the patient's information. Ideally, it's great if you've had a set time and date planned and it's established you're talking about results or a certain thing, but that's not always the case. You can ask, we have results back. Can we talk about them now? Or is there a better time? Or how would you like me to give you information about your test results? What works best for you? And then giving knowledge and information. This can include a warning statement. You might read about that in the literature. Some statements, depending, again, if you talked to them before, this might be more serious than we originally thought, or this might not be the result you were expecting. Now, this might bring up, different emotions. So address emotions with an empathetic response. It's really important not to shy away from emotions, but instead lean into and acknowledge them when they're present in the session. And lastly, for the SPIKES protocol, clearly lay out the next steps. Make sure that you're on the same page and the family knows how to contact you and where they're going from here. So this is the SPIKES protocol and the one I'll go into in the most detail. Like I mentioned, there are more. A, B, C, D, E. This was also created for clinicians in the healthcare field. There's a lot of similarities between the two models. If you look at this, advanced preparation, focusing on communication and emotions. But something I really like about this model specifically is the idea of preparing in advance. And some things I'll point out here. This model encourages people to think about words or phrases to use before the session. You might have read every single thing about this diagnosis, you've read all the literature, you feel really prepared, but do you know how those words are going to come out of your mouth when you find yourself in front of a family? What phrases are you going to use? And can you practice that out loud or with a coworker before you go into the conversation? I like the emphasis on relationship building. And also there's a recommendation within this one to process your own feelings and reflect after the session. I do think it's very important to recognize, of course, these conversations are hard for healthcare providers, but we don't have to do that processing in front of the patient. We can self-reflect later, make sure you're practicing self-care. But as we'll see in a video later, it's not always appropriate to process your emotions in front of the patient when they're actively processing. So the last model I'll briefly mention is Pewter. This was one that was a little newer to me because it was first developed as a tool for school counselors and not as much in the healthcare literature, but it's been really effectively used in the clinical setting when delivering life-changing news to patients. Again, you'll notice many similarities here. Emotional response, it mentions that warning phrase that you can use. But for this one, I really like that as part of T for telling, there's an emphasis on being genuine and sensitive. And then as part of the emotional response, this model acknowledges that it's okay to end a conversation early if that's preferred by the patient receiving the news. It's okay to have multiple conversations if that's needed and preferred. So as you can see, despite being created for different settings, all of these models underscore the importance of preparing for the conversation, allowing emotions to be present, and they're all very patient focused and patient driven, which I think is the most important part. When I work with students, sometimes I notice a tendency to want to just blurt out all the information and educate as fast as you can, or check on all the items on your list. And I've been guilty of this as well. But when someone's processing difficult news, it's important to take a step back and figure out what their agenda is. What are their questions and desires in that moment, and be a little bit flexible with your own agenda. So now that we've learned about these models, I guess we can all go out and deliver difficult news effectively, right? So of course it's easier said than done when I'm talking at you like this and we're going through the acronyms, but I know it can be different in the moment. Didactic lectures in particular, like this webinar, I think they're a great start. We need to raise awareness. We need to start somewhere, but merely knowing what skills to use doesn't actually change behavior always. So let's talk about training methods to actually improve the skill. So based on interviewing medical students and research within different medical curricula, we know that there's both a preference for experiential learning and that it's also more effective. So I'm talking about more hands-on learning, and that could include role playing, working with a simulated patient, or communicating with real patients with a supervisor. It's not enough to talk about the skill once. You can't go to one training and suddenly be an expert, but it's something that develops over time. And there's more literature I find on trainings that improve confidence, which I think is really important, and research on patient preferences. I do hope to see more research on actual patient outcomes like adjustment genetic residency training programs. So here I want to step back because I know for this conference, we have a number of different people in the audience. And so to take a step back, a genetic counselor training is master's level. It's a graduate level degree that's typically about 2 years. So those are the genetic counseling training programs I'm referring to. Genetic residency training programs, this was a little bit harder to pin down and define. I had a geneticist that worked with me on this research, but essentially a geneticist is a physician. They've typically, started by going to med school, oftentimes have done another residency or training before genetics. That could be pediatrics or OBGYN, something different, and then their genetics training. So those were the two groups I was looking at. And my aim in looking at them was to assess the training that genetic counseling students were receiving in delivering difficult news and comparing this with the physician, those clinical geneticists. So to accomplish this, we surveyed program directors, so those that run these programs, and we got their professional perspective on a variety of statements. So this was a Likert scale. So we'd have a statement and then they could strongly disagree or strongly agree in that scale. And then our survey also included some questions about what elements were in each program, who taught them, and then there was definitely a lot of open comment sections. And based on time, let's just highlight a few results. At the time of the study, there were less training programs. We had an excellent response rate of genetic counseling programs, an 85% response rate, and then a bit lower with the residency at about 26%. And something I really like to point out, even though it may seem obvious, is just to emphasize everyone agreed 100% about the importance of delivering difficult news and getting the skill right. I think it's just a good foundation for us to start on to realize something we all agree with. So even though it's really hard, it's recognized as an important skill. And in the comments section, directors did talk about this being crucial and important in and out of clinic. So as I mentioned, through this survey, we also asked about elements, what was included in the training of the different programs. And through literature review, we compiled many common training techniques. One I want to highlight because of its effectiveness in the literature is an OSCE, which I think is more common in medical school training, that observed structural clinical examination, a more formal experience with a simulated patient and actually receiving evaluation and more structured feedback. Other methods that were used were observing in clinic, watching lectures, webinars, all sorts of different things. Now, according to directors, many of these different training methods are being utilized in their programs, which is a great thing. The methods in red here are the ones that were more hands-on or experiential. The asterisk indicates that there is a statistically significant difference in usage between the genetic counseling and those geneticist trainings. Each technique was utilized by at least about a third of genetic counseling programs, and 6 of the 8 techniques was utilized by at least 75% of the programs. The most common one was role play, and I don't think I mentioned this. I teach a psychosocial course for the University of Utah Genetic Counseling Program, and definitely we use role plays quite a bit, so I can confirm that from my personal experience as well. This is another way of comparing that same data. And you can see from the geneticist physicians, the expectation is that the skill was primarily on the job training. So watching supervisors and through clinical encounters, which makes sense when I think about the residents fellows that I've encountered in training and that they're doing so much on the job learning. However, this next point kind of concerned me. In that Likert scale model on my survey, we had asked about the statement, observation of clinical encounters is sufficient training for students in delivering difficult news. And interestingly, while most people disagreed, so 71% disagreed with that statement, of the genetics physicians, 29% actually agreed that it was enough. For the genetic counseling programs, 96% disagreed with that statement. So I think there's a difference here in perception about whether observation or on-the-job training is enough. I guess my concern is if no one's ever been trained any other way, what are they observing, and do we know that it's in alignment with what works in the literature? Now, I also think it's hard for me, at least, to improve on a skill without feedback. So I was curious about what evaluation methods are used. Many genetic counseling programs said that they do evaluate on this skill specifically, so that was 78%, and of the genetics residencies, it was 62%. And from the comment section, we got a better idea of what was being used for evaluation. So in some of these quotes, you can see that the evaluation is more, peer evaluation, group discussion, journaling, and self-reflection. And then in some cases, people are receiving more structured and formal feedback. So we're really all across the board. So those are some of the highlights to me. So what's next for delivering difficult news research? While we've talked about what improves provider confidence and types of training, I want to bring this back to being really patient-centered. There's research about patient preferences, a little bit about outcomes, and like I mentioned, I want to see more about that. And then a family I'll talk about a little later has really stressed to me the importance of what she calls the human component. So consider ways to increase that therapeutic relationship and sensitivity in encounters. To me, there's a bit of a disconnect. So I just presented this research where directors are listing many ways of training for delivering difficult news, and that looks really great. But then anecdotes I hear about it being delivered poorly makes me wonder if providers feel ready at graduation and whether more standardized training would be helpful. Interestingly, 96% of genetic counseling program directors agreed that students leave the program prepared to deliver difficult news. 79% of those genetic residencies directors did. So I do want to acknowledge that there were clearly some limitations in my research with a lower response rate from residency directors. And there's also been an inability to quantify the actual numbers of hours learners spent in each activity. So how much time is being spent in each one, which I would be really interested in. So I know a lot of other genetic counselors and students, primarily in Utah, since that's where I am, that are working on projects about delivering difficult news. And I'm excited to watch as more gets published in this area. Particularly, there's a phenomenon of more and more of these conversations happening by telephone, and it'll be important to study the implications of this change. So now that we have discussed ways to deliver difficult news and training methods, I do have some action items for the audience. For the healthcare providers in the audience, I want us to really bring that human component into delivering difficult news. When delivering difficult news, support families, listen to their lived experience, acknowledge emotions. I know it can be scary, but this is where we are. How would you want your healthcare provider to treat you? Importantly, for many of us, since this is a genetics audience, I think we do need to respect sometimes that a genetic diagnosis is not always a crystal ball. We can provide a balanced education and guidance about potential outcomes, but ultimately that patient or that child is going to show us their full potential. And when I talk to families, that's what I hear most often that they wish their provider had conveyed. You can say, okay, there's a 10% chance of developmental delay and a 50% chance of feeding difficulties, but at the end of the day, just having an honest conversation about, yes, some of these things are increased because of this genetic diagnosis, but here are other things that, we'll see for this child or that we really don't know because it's not a crystal ball. Self-reflect after providing news about what went right and what could have gone better. Start discussions with your colleagues, start discussions in the office. Conversations on this topic with my genetic counseling colleague, like Brianna Sawyer, has led to lots of learning and brainstorming about how to better support patients. Working with my colleagues has shown me the importance of having written information like pamphlets or binders available for families to take home and reference later. So I love that learning from others in this skill. I'm also a big advocate for learning more about the patient experience from patients themselves. They're going to know more about their experience and what they want. So you can, go read family blogs and attend community events. I bring this to the University of Utah Genetic Counseling Graduate Program by planning something called a family match, in which the students talk to a family with a genetic diagnosis in the community about their experiences with healthcare. Students often learn how families first heard about a diagnosis or other news. I was excited this morning to realize that Heidi Wallace, a big advocate in the genetics community here in Salt Lake that has helped with the training program, is also a co-lead for the MSRGN state team. So just reaffirms the great people in this organization. Since I find it important to listen to families, I wanted to respect and listen to the families of the Mountain State Regional Genetics Network that told me they really appreciated resources from ABLE New Hampshire and the Fostering Joy Project. So that second one focuses on the deaf community. I've explored both websites and feel like they emphasize the importance of neutral language, not putting your bias on news for the family, respecting emotions, and throughout your relationship with a patient or family, celebrating the little things and the wins. So I do have a 4-minute video from ABLE. Well, let me just stop sharing my screen really quick and pull up their website for us all. So bear with me. We saw earlier that technology is not my strong suit. But here is what the video looks like if you want to check it out. And here's that video.
When the doctor came in, you could tell that she was emotionally torn up. All that emotional work that we had done to be okay with the diagnosis was really, it was undone in 5 seconds. And all of a sudden it was like, this was the hardest news that we could have received. What was so important was for us to have space to react on our own as opposed to absorbing her reaction.
The doctor comes in, he was like, where's your son? Where's Josh? I'm like, what do you mean? The nurse said you just wanted to talk to us. No, I need to see him. I think he has something called tuberous sclerosis. This was like my big project in school. It's the first time I've seen it, so exciting. Let's put you in Johnny's, let's try this and test it out. I'm not a science project. I understand it's exciting that it's the first time you've seen it, but take a step back, put yourself in their shoes, stop and think about what you're gonna say and who you're telling.
When I was an infant, doctors told my parents I'd likely never learn to talk, read, or ride a bicycle. They were told I'd be living in an institution someday. Well, it's not true.
The biggest goal would be to eliminate the healthcare provider's cultural bias when delivering any kind of news to the patients. They shouldn't present it as negative. This is just news. It's not devastating news, and we should be able to support the patient through this journey and kind of walk them through it so that they're not alone and feeling like they have to make a life-altering decision in this very vulnerable state.
When they see these abnormalities, one of the first questions a genetic counselor asks you is, how will you proceed with the results? Like, what are you thinking? Which I just think that's not a helpful question to ask up front. I was just really surprised at the lack of resources that they had in the hospital.
And just for the sake of time, I'm going to move forward a little bit to this next patient experience here.
Doctor, immediately from the moment that we entered the room, had a sense of comfortability, and he asked me to share my story. That was how the session began. It was empowering. He was so empathetic. He listened to what I had to say. He observed my child. He played with Ryan a little bit. He interacted with him.
So I'm gonna stop it there. I know Christy said they'd be able to share the whole link with everyone if people want to watch the whole video, but for the sake of time, let me just go back to our PowerPoint here. Okay. So just in that video, I wanted to relate this back to the models and research. So in those first examples, those first two examples where patients weren't as happy, providers were focusing on their own emotions. They were excited or sad, and families ended up feeling lost or confused. In that good example near the end, that family felt supported, they felt heard, and they left feeling empowered. So I wanted to introduce you to Lennon and Katie. When Katie heard I was doing this talk, she's the one that brought up that human component to me as something she wished was more present in healthcare and difficult conversations. Her daughter Lennon here has Prader-Willi syndrome, and you can see that first picture of her as a newborn versus at her preschool graduation and skiing with her mom. So Katie wanted me to share, she's part of that family match that I mentioned, and she participates in genetic counseling. It's really important because of her own experience. She professionally does work with people with disabilities, so she acknowledges it's difficult to have these conversations. It can be overwhelming or emotional, but she remembers when she received news about her daughter that it was done in more of a flippant manner. She remembers the genetic counselor mentioning that she had not seen a patient after diagnosis except at the grocery store. So for me, it just really emphasizes that we have to be thoughtful about our words and our actions at this time. People might remember receiving difficult news for years to come or even the rest of their lives. So this is really impactful. So to close, I hope we can all reflect on the importance of bringing compassionate care to the table when we're delivering difficult news. As you've heard, there's tools and research out there, and I'd like to empower you all to go have these conversations. You can do it, and I have just a few seconds clip.
Lennon, did you hike this yourself?
Yeah.
Yeah? What do we say?
I can.
I can?
Yeah. Yes, I can do it.
So that was our little friend Lennon that I was just telling you about. And she says, yes, I can do it. And I want to empower everyone that's been listening and to end the talk today and this conference day saying, yes, I can do it. You have what you need to go out and deliver difficult news. We can do this. We can do better for ourselves and for our patients. So thank you for your attention today. I wanted to acknowledge in particular Dr. John Carey and Karen Dent, that they both really inspired me and made me passionate about delivering difficult news and supported my student research in a big way. So thank you so much to them and everyone who's made this possible. Lots of references and reading that went into this talk. And so now I think I'm right about at time here for questions.
All right, thank you, Layla, for the fantastic presentation. And I loved all the videos and everything you went through. I don't think we have any questions yet in the moment. Last time I checked, we had about 150 people tuning in live, so I invite you all to submit those questions. But I'll just start it off with, is there anything else you wanted to include in the presentation that you maybe didn't get to for time?
Yeah, it's so funny because when I practice, I was telling you all earlier that I was running short on time, or, it wasn't long enough. And then in the moment I was running short on time. But I think the main thing that I cut out was I would really encourage people to go watch that Able New Hampshire video and, maybe go watch other videos like that and try to apply those frameworks, because I know that's really helpful for me. I can't emphasize enough how important it is to listen to those patient experiences and try to match them up with those different skills. Like, oh, I heard that they used setting up the interview from the Spikes protocol, and thinking about how you can put that in your practice. So.
Great reply, thank you. We do have a question from Christy. Where would you recommend genetic professionals go to get more training if they feel they would like to improve their skills?
Yeah, so I guess the first thing is we talked about the resources that families had given me. So going to some of those patient advocacy groups themselves and learning directly from the patient, since I always think that's the number one best thing, going and reading some of that literature. And then, as I mentioned, I hope there are some people in the audience that are in a position where they are related to a training program or work on fellowship training. I would hope that they could try to incorporate that more. But if you're not actually either in charge of a training program or in a training program, I think that one of the best things is to just practice with colleagues, like just write out what would you want to say depending on these different protocols using these acronyms. Practice with colleagues, have people watch and give you information. Right now, I had mentioned in my talk that there are a couple of studies going on, and for genetic counselors in particular, the research, it's still open. The study by Alex Finley actually has a genetic counselor delivering difficult news training program, which includes a module about delivering difficult news, working with a simulated patient, and observing examples of delivering difficult news. So if you could participate in that study, there's been blasts about it through the National Society of Genetic Counselors. That's a really good opportunity as well. And I'll talk. I hope that Dr. Carey or Karen are part of this talk. So if we can think of some more good websites, I'll make sure to pass them along to Christy.
I'm sure we can make that happen. Next question. Are there any days or times of the day you would avoid giving difficult news? Maybe 4 p.m. on a Friday afternoon.
A good question, and also someone gave a really good example, and I think that's why, if possible, that contracting in advance. So if it's a test result, contracting and saying, what are good times for you? I've had some families that tell me, I work night shifts, I sleep all day, so I actually want this news later at night. So if, as much as possible, I think people do have different preferences about this. If it is something that doesn't have to be done on a holiday, at the very end of the day, I know my colleague and I have always talked about how bad we feel if we've tried to reach someone at the very end of the day and then have to leave a voicemail. What if they get that voicemail, can't reach us all night, and are stressed about it? So as much as possible, respect that patient preference. But I do agree that end of the day or right on a holiday or end of the day Friday are tough. I also try to watch for like patient birthdays and, not wanting to give difficult news on a day like that's a celebration.
Makes sense. We have about 4 more minutes left for Q&A. We don't really have any questions. We do have a good number of comments on great feedback on your presentation. And then the link to the video you shared is also in the chat. Stephen Keller wants to note that, just a comment, one of the most useful questions they found to use at any visit is, what is your child good at? They say it completely changes the fear and uncertainty that may be in the room. Would you agree with that? Any other particularly big questions?
I really agree with that. And just in general, when I'm working with students or when something I teach them when taking the medical history, that's a great time to really involve the child and then also to ask those types of questions and build that relationship. So asking questions when you're asking about a child's diet, you could also ask, what's your favorite food? What's your favorite color? Like just some fun things there. And some of those resources I talked about really talk about celebrating the milestones. So instead of hearing a milestone and saying, wow, that's so delayed, really listening to the family. Sometimes they'll say, she just started walking and maybe it was at 20 months, but we're really excited and really honoring that and celebrating with them. The other, not to steal from you, Cody, but I did see that Christy had asked about resources specific for primary care providers and pediatrician. They might be delivering slightly different news than genetic professionals. And one thing I will underscore is that a lot of what I talked about, I did talk about genetics program training, is actually that all of those models, some were for oncologists, some were for school counselors, they're not really necessarily for genetics providers. And that when I read the literature, a lot of communication training and those skills are applicable all across different areas of healthcare. So I will emphasize that as well.
I'm just scanning through the questions. We've got about 2 minutes left. Have you solved the new CARES Act rule that results become instantly available to patients or families?
So I have heard about that. I do know, depending on different healthcare systems and their electronic medical record, and depending how on top of the electronic medical record people are, different ways that that's played out. I do think that as much as possible, healthcare providers should know how that's impacting their institution, and if a patient would get a result before they get to it or have a chance, make sure that they have some expectation about when that result would be back and talk to a family to be available for follow-up. I do think that can be difficult.
Okay, we've got one last question with an upvote. Do you have any formalized process for finding out how patients prefer to receive test results? For example, is this something you routinely ask about during your medical intake or on intake forms? If you could respond in maybe 15, 30 seconds.
Yeah, so if your institution does use intake forms, I suppose you could try that. I haven't heard of it. Normally it's verbally just asking if we know we're ordering a test and have to return it, just simply asking during the encounter and noting that down.
All right, I see we're at 3:20 Central Time. I know we've got everybody from a bunch of different time zones, but thank you for the excellent presentation, Layla.